Good afternoon to everyone. So I'm going to discuss mechanisms of resistance to BRAF inhibitors, and probably some of the slides have been already discussed by Dr. Ullas sir, and regarding the subsequent treatment post-resistance. So allow me a brief introduction. This has been already discussed. Based upon the population that is studied, the incidence can be varying anywhere from 1.7% to 4.9%. Let me reiterate the BRAF mutations of interest are the V600E. This happens in the exon 15, codon 600 variant to glutamic acid substitutions. And the other non-V600E mutations are classified as class 2 and class 3. They have a very unique clinical and pathological phenotype. The V600E mutations, these are found more commonly in non-smoking women, and they have aggressive adenocarcinoma micropapillary histology. And the class 2 and class 3 can also have adenocarcinoma or sarcomatoid differentiation or squamous cell carcinoma. These are much more common in men who are smokers. So sensitive to BRAF inhibitors is exclusively to the V600E mutation. And we can see that previously discussed, the monotherapy can have a response rates of anywhere between 30 to 40%. The PFS can range anywhere from 5 to 7 months. The combination has a better response rates of 65%, and PFS rates come in around 10 to 11 months. So I will not discuss the molecular mechanisms. These have been previously discussed. Unfortunately, all these patients will eventually have a progressive disease, and we are going to discuss the mechanisms of resistance, which could be inherent, which is a primary resistance, or the acquired or secondary resistance. Much of the information is coming from the metastatic melanoma, and the information regarding the resistance pathways in non-small cell lung cancer is poorly defined, but we can make that correlate that most of the mechanisms are interchangeable between the solid tumors. So even in metastatic melanoma, the BRAF V600E inhibitors, they have a very good response rates to the tune of 60%, and they have been randomizedly compared with dacarbazine and have shown to have increased PFS and increased overall survival rates. Despite this promising activity, nearly about 50% of the patients, when put on these drugs, will develop early progressive disease within months of initiation of treatment. And this differential response is because of the attributed to the inherent BRAF resistance mechanisms. There are at least 3 different varieties of inherent resistance mechanisms. This includes the upregulations of the other isoforms of RAF protein, which is the ARAF and CRAF protein, that can activate the MAP kinase pathway and whenever the BRAF is inhibited. There could be other methods in which the BRAF can be bypassed, which is the MAP3K8 and COT stimulation of the ERK. To an extent, the combination of BRAF inhibitors and MEK inhibitors can overcome this resistance. Finally, we come to the PTEN loss of function alterations. If you look at BRAF V600E mutation, it's an oncogene mutually exclusive mutation. The cancer cells is addicted to the mitogenic stimulus that is provided by the BRAF mutation. And when there are BRAF inhibitors, these cancer cells will go on to have the apoptosis, which is BIM-mediated apoptosis. By having the PTEN loss or PA3K mutation, this BIM-mediated apoptosis is lost and the cancer cell has a survival advantage. Coming to the mechanisms of secondary resistance, it could be persistent activation of the other receptor tyrosine kinases, which includes PDGFR, insulin growth factor, and epidermal growth factor receptors. There could be mutations in the KRAS, including NRAS. There could be BRAF amplification. There could be apparent splicing of BRAF protein, which makes them insensitive to the BRAF inhibitors. And there could be mutational and epigenetic changes affecting the BRAF as well. So here I would like to reiterate that RAS gene might be a critical gene modulator in the resistance mechanism to the combination therapy. If you look at the basal state, this is a very tightly regulated mechanism. Ligand-activated receptor tyrosine kinase activation results in the phosphorylation of the RAS isoforms, which are the NRAS, KRAS, and HRAS. And after the RAS activation, it results in the phosphorylation of the RAS, which forms a homodimers and subsequently drives the mitogenic stimulus. In the oncogenic BRAF mutation profile, the monomers of the BRAF V600E are constitutionally activated, and this drives the subsequent mutagenic stimulation. And in the presence of BRAF inhibitors, there could be a secondary KRAS mutation, which could be KRAS G12D, which locks the RAS in a constitutionally activated phase, which can drive the subsequent stimulation. So this is a case report which I picked up from the JCO. Basically, this is a patient who had a BRAF V600E mutation. We can see that this patient was eligible for a clinical trial. This was at Johns Hopkins University, and this patient was offered dabrafenib and subsequently had a very good response at 4 months. And at the time of disease progression at around 8 months, the biopsy was repeated. As you can see, the initial mutation profile was conserved, saying that this is the clonogenicity of the tumor. And subsequently, there are further more mutations in the KRAS, TP53, and cyclin A. And the authors have postulated that the KRAS G12D mutation is what is driving the tumor progression. There's another report of a patient who has received dabrafenib plus trametinib and acquired NRAS Q61K mutation at the time of disease progression. So coming to the options of subsequent treatment, the ideal would be to target the resistant mechanisms like KRAS. The other options include treating the cancer as those without targetable mutations, which includes immunotherapy, chemotherapy, and combination. So this is an abstract which was presented at ESMO 2020, and this was picked up from the Annals of Oncology 2020 edition. In this, we can see there are two drugs, which are the BRAF inhibitors as well as the ERK1/2 inhibitors, the LXH254 and LTT462. These two drugs have shown preclinical activity in the MAC kinase pathway-driven xenograft models, and they've also been evaluated as a single agents in the phase 1 dose-finding studies. And in this phase 1b study, the combination drugs have been tested for their safety and efficacy. And around 49 patients were enrolled, and they had at least 33% stable disease, including 2 partial responses. So this combination is well tolerated, and preliminary signs of efficacy was seen, and a dose expansion study is ongoing. This is one of the methods in which we can actually target the acquired resistance of KRAS along with the BRAF mutations. Coming to the immunotherapy in BRAF mutant non-small cell lung cancer, as related by the Dr. Ullas Batra sir, this has already been shown. Basically, when we look at the oncology-driven non-small cell lung cancer, these patients are having a high PD-L1 percentage, but unfortunately not very good response with the immunotherapy. This is not the case with the BRAF mutations. This is a retrospective multi-center chart review from Israel. They included around 44 patients who have been treated with the immune checkpoint inhibitors and have BRAF mutations. They have reported the PD-L1 levels, TMB levels, as well as MSS status in both BRAF and BRAF V600E and non-V600E mutations. As you can see, the characteristics, the PD-L1 high, which is more than 50%, was significantly higher in non-V600E at 50% compared to 42%. The tumor mutation burden was also high in the non-V600E. If you look at the overall response rate, it's not much different, 25% versus 33%, and also the PFS, which is 3.7 months versus 4.1 months. So the authors have concluded that the BRAF mutated non-small cell lung cancer appear to have high expression of PD-L1, but this PD-L1 status or the mutation expression, BRAF mutation type, did not alter the outcomes. Similarly, we have a retrospective study from France, which included around 21 centers. Out of the 44 patients who have been treated with immune checkpoint inhibitors and BRAF mutations, we can see that overall response rates are pretty much similar between the V600E versus non-V600E, which is 26% versus 35%. The median duration of response was also similar, not reached versus 13.1 months. The PFS was also similar at 5.3 months versus 4.9 months. The OS is very different. It is 22.5 months in the V600E compared to 12 months in the non-V600E, probably contributed by the utilization of the BRAF inhibitors. Again, this retrospective was being highlighted in the previous lecture as well. The immune target registry, around 43 patients with BRAF mutations have been enrolled. Basically, the PFS was significantly higher in smokers compared to non-smokers at 4.1 months versus 1.9 months. Among the patients who had the analysis of PD-L1 status, the median percentage of cells expressing the PD-L1 was 50%. So there appears to be some activity of immune checkpoint inhibitors in those patients who are having BRAF mutations. Coming to the chemotherapy and chemoimmunotherapy combinations, chemotherapy, when given in other basically the oncogene-driven mutations, basically what happens is the ALK and as well as ROS has some chemosensitivity, and we can expect some good responses even in those patients who are taking chemotherapy with ALK and ROS mutations. EGFR is something similar to the entire cohort. They can have some responses, but the BRAF V600 mutations patients appear to have a very poor prognosis when administered with chemotherapy alone. And they appear to be insensitive to platinum-based chemotherapy as well. Coming to the chemoimmunotherapy combination, these are the case reports I have picked up from the literature review. Basically, this is a patient who has been treated with immunotherapy and platinum-based combination chemotherapy, atezolizumab plus platinum-based combination chemotherapy in the front line. At the time of disease progression, patient was identified with a BRAF V600 mutation, and this patient went on to had a good response even with the second-line dabrafenib. The second case report, which I have been highlighting here, is a patient who has taken a combination of dabrafenib and trametinib in the front line, and subsequently went on to receive pembrolizumab with some good clinical benefit. So as of now, both the combinations appear to be having some effect. the immune checkpoint inhibitors appear to be having some similar results, like 23 to 34% response rates with a PFS rate of around 5 to 6 months. So coming to the future studies, it is easier for a BRAF non-small cell lung cancer to follow the BRAF mutated metastatic in melanoma. There are clinical trials in the melanoma that have suggested activities of combination of immune checkpoint inhibitors with BRAF targeted therapy, but data is limited in non-small cell lung cancer for regarding safety and efficacy. However, there are several clinical trials that are actively recruiting that utilizes the combination of immunotherapy with MEK inhibitors. Atezolizumab is comimetinib, pembrolizumab plus trametinib, and pembrolizumab plus trametinib in other clinical trial. So in conclusion, the randomized clinical trial data in non-small cell lung cancer with BRAF mutation is not forthcoming because of the low incidence of these mutations. The RAS gene might be a critical gene modulator in resistance mechanism to combination therapy. The current targeted therapy are exclusively for the BRAF V600E mutation, and there are poorer efficacy against non-V600E mutation. And studies have demonstrated that immune checkpoint inhibitors have some efficacy in this population. And the problem that lies ahead is which regimen should be given first. Personally, I feel that both these drugs have effect in this BRAF mutated non-small cell lung cancer patient. We need to be very vigilant regarding the performance status and their quality of life and use both the drugs. And the combination is experimental as of now. We are eagerly waiting the further clinical trial data. With that, I would like to conclude my talk. Thank you very much.
Thank you, Dr. Rakesh. As always, a comprehensive and crisp message. So